slow up, no I don't take shit. I got no love for the fakeness. If you wanna play tough and wanna hate this, I'll always show up.
On our channel today, I have a surprise for you guys. We're gonna go over the Hematology Oncology episode 2, but we're gonna use Manus, and Manus is a new GPT that only certain individuals are able to access it. And I recently received the early access to Manus, and I wanted to kind of use it and see how it does in terms of creating questions. So as you know, on my channel, we basically create board questions using AI. And these board questions are created in this format, certain structure, using my instructions that I have developed over the last few months, and the educational objectives that come from various resources such as the MKSAP, UWorld Internal Medicine, and other board approved and resources like AMBOSS and those companies as well. So I use the medical concepts that are getting tested, and I create board questions using these various AI tools, and have them answer these questions in a way that they're very, very understandable. And in that way, we can tackle all aspects of that medical concept so we don't miss it on the exam day. So let's go ahead and get started. This is the first question. This is a 62-year-old man who presents with a PCP with complaints of fatigue, unintentional weight loss of 15 pounds over the 3 months, and occasional left upper quadrant discomfort. Physical exam reveals a splenomegaly. Lab studies show hemoglobin 10.2, platelet count of 650,000, with a white count of 78,000, with a differential showing predominantly mature neutrophils. Peripheral blood smear shows leukocytosis without significant blasts. Which of the following is the most appropriate next step in the diagnosis of this patient? So go ahead and pause the video right here, pick your answer, and then we're going to go through the options together. All right. So of course, let's talk about the diagnosis, and we're going to go through the options. So this is CML, right? So the patient has CML, which is the myeloproliferative neoplasm characterized by the unregulated growth of myeloid cells in the bone marrow. The hallmark genetic abnormality is the Philadelphia chromosome. Remember, a reciprocal translocation between chromosome 9 and 22, T922. Resulting in the BCR-ABL1 fusion gene. The fusion gene encodes a constitutively active tyrosine kinase that drives the uncontrolled cell proliferation. So very detailed and great, kind of explanation on the pathophysiology of CML. Most importantly, that we need to know for internal medicine is the phases of CML as well. So we have a CML that's in chronic phase. That's 85% of the patients at diagnosis, and these people will have less than 10% blasts in their blood or bone marrow. Then accelerated phase, which would be 10 to 19% blasts, progressive leukocytosis, and then they have the blast phase, which is greater than 20% blast, and this would resemble basically acute leukemia. So just by seeing how this is categorized, you can tell that the first thing you would gonna get is a bone marrow biopsy and a cytogenetic analysis, but because that's how you can tell which phase these patients are in. So this patient in presentation has fatigue, weight loss, splenomegaly, anemia, thrombocytosis, and marked leukocytosis without significant blasts, which basically tells you, like most other patients, the chronic phase of the CML, and probably most likely being tested on boards. But key clues on this is that they give you the the age, the symptoms. The splenomegaly is actually a very important classic finding in CML because of the extramedullary hematopoiesis, right? All the CBC findings, and then absence of the significant blasts. So option B was to get a CT scan. It could help with the splenomegaly, but doesn't help with the diagnosis. SPEP, if you were thinking about plasma cell dyscrasias, not really myeloproliferative disorders. Flow cytometry more useful in acute leukemias, right, or lymphoid malignancies. The JAK2 mutation, genetic. So this is associated with myeloproliferative neoplasms such as polycythemia vera, essential thrombocythemia, and myelofibrosis, and not really the CML. So just remember, these would be the myeloproliferative neoplasms if you were to go over JAK2 mutations. So as you can see, and you compare to our prior videos on GPT, this seems a little more, I would say, complex in terms of the answers and a little more deeper into the answers and explanations. So the algorithm for decision making, and as you can see, these are all my format. I have asked it to create these in the way that it is doing it right now. So when approaching a patient with unexplained leukocytosis, splenomegaly, and constitutional symptoms, get the CBC, get the peripheral blood smear, get the bone marrow biopsy with cytogenic analysis to identify that Philadelphia chromosome, and then you can do your molecular testing for BCR-ABL1 fusion gene, or FISH or PCR. And so for suspected CML, definitive diagnosis requires identification of that Philadelphia chromosome or BCR-ABL fusion, making bone marrow biopsy with cytogenic analysis the essential next step. So this is very, very important, right? So you first understand what the diagnosis is, then know that you really need a bone marrow biopsy to confirm it, okay? And this is kind of, again, going to pattern recognition about, you know, the findings with the white count, elderly patient with splenomegaly, and absence of blast, kind of hitting nail on the head multiple times to make sure that we never forget this presentation. And yeah, so kind of repeating there, and then going through the guidelines. I actually did a really good job here too. So according to the National Comprehensive Cancer Network NCCN guidelines, the diagnosis of CML requires demonstration of Philadelphia chromosome or BCR-ABL1 fusion gene. Bone marrow exam with cytogenetics is recommended. Fluorescence in situ hybridization or FISH or quantitative PCR for BCR-ABL1 should be performed if the cytogenetics is negative. And the first line therapy, remember, for chronic phase CML is a TKI or a tyrosine kinase inhibitor, such as imatinib, nilotinib, dasatinib, or bosutinib. Response monitoring includes regular BCR-ABL1 quantification by PCR, and then the allogeneic stem cell transplantation is considered for patients with advanced disease or those who fail multiple TKIs. So basically, with one question, you can see how every step could be tested, right? Like all of these steps that you could in diagnosis could be tested, and the basically the stages of CML could be tested based on the blasts that you find, and then the treatment for the chronic phase can be tested that we talked about, right? And multiple levels of it too. Like if they say, oh, they were on TKI and they failed, and then the next step in the treatment, you know. So multi-level diagnosis, multi-level treatments. So as you can see, it's very comprehensive. Manus is giving us a lot more information so for that same kind of educational objective. Now in the first part, when I put this in, Manus actually created 5 questions with that same objective, which is very, very good. I'll try to incorporate them into the notes on my Patreon, but it did a really, really good job. And this one was again diagnostics, asking about diagnostics, and again went through the whole process on this one. This was related to describing the patient response to therapy. How would you basically see the response to therapy? How would you monitor? Like, I mean, it did a really, really comprehensive breakdown. So that's that. So let's see. So this is another one. I'm trying to get through them so we can go to our next question. Okay. Yeah, there's another one. I think this would be the 5th one. And yeah, and I told her I only need 1, so don't give me like 5. All right. So let's go ahead and go through this question now. So we got a 62-year-old woman with metastatic breast cancer. She presents to the ED with severe pain. She rates it 9 out of 10 in her lower back. It began 2 days ago. She reports that Tylenol and ibuprofen provide minimal relief. Her vital signs are stable. Physical exam reveals a point tenderness over L3, L4 vertebrae. Recent imaging shows bone metastasis in multiple vertebrae. Which of the following is the most appropriate initial pain management strategy? So go ahead and pause the video right here, pick your answer, and then we're going to go through what's going on with this patient and how to treat her. All right. So let's go through them. So basically, this is pain management, right? Pain management is always on internal medicine boards, so very important to know. So cancer pain, especially, is very important. So this patient has, cancer pain has multiple mechanisms in general, particularly on those with people who have bone disease, metastatic bone disease. So nociceptive pain is activation of pain receptor by the tumor invasion and inflammation. Okay, that's one way. Neuropathic pain, basically compression of the nerves or infiltration by tumors into the nerves. Inflammatory pain, which is basically release of those cytokines and the prostaglandins, right? So it can cause severe pain. Bone mets can cause severe pain through all these mechanisms: direct invasion into the periosteum, microfractures and structural instability, release of inflammatory mediators, intraosseous pressure increase, nerve compression. So very, very difficult to deal with because the amount of pain that it can cause, especially at when it metastasizes to the bone. So the severity of the pain is also very important. So in her case, the severity was 9 out of 10. Indicates that there's significant nociceptive stimulation requiring a potent analgesia. So the WHO pain ladder, which we use to decide how much pain management we want to use in a patient, using the intensity becomes very important. And someone with cancer pain at 9 out of 10, it's basically an immediate initiation for stronger opioids. So in our case, there was oral morphine in our option, which would be the correct answer. So key information in this case: again, metastatic breast cancer, severe pain, minimum relief with non-opioids, point tenderness on the vertebrae. And when you go through the options, so the first one was Tylenol and celecoxib. Of course, non-opioid analgesics will not cut it. Option B, immediate release oral morphine. This is strong opioid appropriate for severe pain. This is what we want to do. This is the correct option. The transdermal fentanyl would be a long-acting opioid and is not appropriate for initial management. Even though some people may think, oh, because there's a point tenderness there, just stick a fentanyl patch. Really, it's not. It's the one that people usually get wrong. But because you need to understand, we don't go to a long-acting opioid for initial management of severe pain. Tramadol, weak opioid, insufficient for severe cancer. Gabapentin would be if the patient presented with neuropathic pain and not really here with a severe acute pain, which is basically more bone pain. So this is the 3-step ladder of WHO for pain management, cancer pain management. So mild pain between 1 to 3 over 10, you can use the Tylenol and NSAIDs, maybe some adjuvant. Step 2, 4 to 6, weaker opioids are good. Codeine, tramadol, you can use. 7 to 10, then you start thinking about morphine, oxycodone, and hydromorphone. You can add some adjuvant medications and the non-opioid analgesics as well. And usually, if you have a severe pain in this, like in our case, just remember to go through each step. And this is kind of like telling you when you have how to go through the ladder. Skip the steps 1 and 2. Start with short acting. Add non-opioid analgesics for multimodal analgesia. Consider adjuvants based on main pain characteristics, whatever you need to add. And then once the pain is controlled, you can convert to long-acting opioid with breakthrough medication, which is very important. See, this is another way they can ask you. The patient pain becomes controlled on short-acting. What's the next step? That's another question right there. Each of these levels, based on the pain that the patient has, they get tested on the boards. So one question, see how many ways they can be tested. Pattern recognition, kind of going through the whole thing we talked about, and red flags that indicate need for stronger opioids are there: metastatic cancer, bone mets, severe pain, failure of non-opioids, right? Pretty good there. And going through again, this is the NCCN and the American Society of Clinical Oncology, ASCO, and the American Pain Society guidelines kind of follows the exact same for the severe cancer pain, right? Stronger opioids, use short acting, Initially, morphine is first line. Strong opioid due to familiarity, efficacy, and cost. Initial oral morphine dose 5 to 15 milligrams every 4 hours. So it even gives you the dose, which is really good. So in practice, and then reassess frequently and titrate the dose by 25 to 50% until pain control achieved. And then once the pain is controlled with short acting, calculate the 24-hour period opioid requirement, and then give an equivalent dose of a long acting, and then you can continue short acting for breakthrough pain. Basically the 10 to 20% of that 24-hour dose. Okay, and don't forget the multimodal approach. That is very important. And yeah, so immediate release oral morphine 10 milligrams every 4 hours as needed, and then titrate after 24 hours, add a long acting, and then continue the short for breakthrough. All right, and let's go through the last question, guys. These are way more involved than the GPT answers, and there's a way more there's also a lot more ways that it shows you that you could be tested. So it's really good. It even gives you more details on the doses and such. Okay. So 68-year-old man with a 40-pack year smoking history presents with a 2-month history of progressive cough, hemoptysis, and 12-pound or 15-pound weight loss. The chest CT reveals a 4.5 centimeter hilar mass in the right lung with ipsilateral mediastinal lymphadenopathy. The bronch and biopsy confirm small cell lung cancer. PET-CT with no distant mets. So we gotta basically, you need to by now you need to know which stage this is. Is it limited stage or is it extensive? Which of the following is the most appropriate initial treatment approach? And then remember what to do as initial treatment for that stage of a patient with small cell lung cancer. Go ahead and pause the video right here, pick your answer. We're going to go through the options together. All right. So, of course, small cell lung cancer is very aggressive. It's a neuroendocrine tumor. It's associated with smoking. It arises from the pulmonary neuroendocrine cells, and it also tells you, the rapid dabbling time, early disseminated via lymphatic and hematogenous routes, high mitotic rates. So it gives you a little details on that. Expression of the neuroendocrine markers. So you would have chromogranin A. So SCLC typically presents with a central hilar mass with early mediastinal spread. The tumor's rapid growth leads to early symptoms including cough, hemoptysis, dyspnea, and systemic symptoms. So I've had patients with SLC. That's totally true. Basically didn't have it. All of a sudden they start developing hemoptysis, and they come to the ER, and we usually get these patients admitted for further workup. Despite being highly sensitive to chemotherapy and radiation initially, SCLC frequently recurs due to the development of treatment resistance. So this is another clinical peril that you need to know. There's a very recurring kind of tumor, and these patients may actually have it treated once, and then a few years later they start having hemoptysis. They come to the ER. I've seen so many of these lung cancer patients. Unfortunately, with the rate of smoking, unfortunately these cancers are common. So let's go over the key information in this case. So we got a heavy smoker, right? We know that it's central hilar mass and it's ipsilateral mediastinal lymphadenopathy. There's no evidence of distant mets, and the SCLC is actually confirmed on histology. So based on just this confinement to one hemithorax and a regional lymph node, this is called a limited stage SCLC, right? So option A would be wrong because it's surgery and adjuvant chemotherapy. Surgery is rarely, SCLC usually rarely treated with surgically, as you know. Remember that it is microscopic, and that's why it's called small cell. And so it's not going to be surgically treated. Neoadjuvant chemotherapy plus surgery, again, that part would be wrong. Concurrent chemoradiation, that is the correct standard of care. These cancers actually really respond really well to platinum-based chemotherapies, and so for a limited stage, concurrent chemoradiation is indicated. Immunotherapy is usually not the initial monotherapy, and then the chemotherapy alone is reserved for extensive stage disease. Limited stage benefits from addition of radiation. So this would be also incorrect. So when we go through, just remember how to characterize the stage of the disease. Limited stage is confined to one hemithorax with regional lymph nodes. incompassable in a single radiation field. And then the extensive stage is when you have it beyond one hemithorax, malignant pleural pericardial effusions or distant nets are present. And remember, for first limited stage SLC, we can do concurrent chemoradiation, especially the platinum-based, like cisplatin, carboplatin plus etoposide. This can be tested right here. What is the first line in therapy? They may say concurrent chemorate, or they may give you the name, say cisplatin plus etoposide, and then make you pick between the option radiation. Early concurrent thoracic radiation started with cycle 1 or 2, and then prophylactic cranial irradiation for those with good response. So that would be the limited stage, and they can ask all these questions. These are all fair game, and I've seen questions on both MKSAP and UWorld that you need to know this. And then the extensive stage SCLC, which is the first line therapy, would be a systemic chemotherapy. Consider adding immunotherapy and such as these MAB drugs. Maybe they will ask, but probably not, because there's just too many. Consider thoracic radiation for responders. If they respond to that, they may consider it. And then consider PCI, the prophylactic cranial radiation, again with good performance status. And then the patient has limited stage, so we need concurrent chemo radiation in this case. And again, kind of goes through the pattern, understanding limited stage and what the treatment is and why it's a limited stage. The red flags of that would indicate small cell lung cancer or the rapid symptoms, the location of and then associate some paraneoplastic syndromes that can present, right? You may have SIADH from these as well. And then the guidelines kind of going over a little more details, right? The concurrent chemorad, what are these? Cisplatin, etoposide. It tells you even the number of cycles. There are some alternatives. Thoracic radiation early, it gives you the radiation dose, and then tell you about that intracranial kind of prophylactic radiation that goes also. The extensive stage, they put the platinum and etoposide plus immunotherapy, and there's no radiation unless they respond, if they respond, and then you can try thoracic, but initially it's chemo and adding immunotherapy. And response assessment, imaging after 2-3 cycles at completion of therapy, surveillance every 3-4 months. Again, more details when you're going over these questions. So yeah, that's it for today, guys. I hope you guys are learning. If you're enjoying these episodes, don't forget to drop a like, comment, subscribe. Let me know what you think about Manus. I think it's very interesting. It's kind of detailed, a little more detailed and involved than GPT, but of course it has its place. And I think I'm glad I picked Hemonc for this episode, because Hemonc is actually more convoluted and really needs a little more, thinking, deep thinking, machine thinking when you go through, because of the stages and the treatments and things that you can add. So I'm actually thinking that we may be using Manus even more now that I have access, early access basically. So let's see what we can do with it. If you guys are enjoying, don't forget to click all those buttons. Follow my Patreon for the notes. I'll try to include all these notes on there. If you guys want to donate for any of these notes, it would be great. If not, well, you can just watch the video and you'll have them anyway. So
Slow up, no I don't take shit. I got no love for the fakeness. If you wanna play tough and wanna hate this, I'll always show up.